My name is Tavia, and I am the Director of Special Projects at Evolve Egg Freeze Clinic. And I mentioned this before, but I wanted to run through it again. The purpose of this event, this speaker series, is really to answer any questions that healthcare practitioners or bring forward different learning opportunities for healthcare practitioners to advance their understanding, advance their education in the fertility space. We often have doctors reaching out to us to ask for some information, ask for clarification. And at Evolve, we really pride ourselves in educating our patients on their own future fertility, on their own fertility needs, and looking at their own goals. And so we just kind of thought, why not, go and reach out to their healthcare practitioners as well. So that's why we started this speaker series, and we hope that you're enjoying it. Tonight we have Conceive Health with us. That was a bit of a tongue twister. And I have Dr. Jennifer Fitzgerald, and she's a naturopathic doctor at Conceive, and I'll let her take it away. She can give you a little bit of a background on herself, and she's going to cover the 90 days of preconception. Oh, before I let her take it away, I forgot as well, if you ever have questions, you can enter them in the Q&A box, and we will take them up at the end of the session.
Okay, so hi everyone. Thanks so much for joining us this evening. I'm Dr. Jennifer Fitzgerald. I'm a naturopathic doctor, and I'm one of the co-founders of Conceive Health, and we are one of the first and biggest preconception or integrative preconception clinics in North America, probably. So we have a few locations scattered across the GTA, and we are basically providing services to patients who are trying to conceive, those who might be seeking fertility treatment, or those who might be trying to preserve their fertility for future. So tonight I'm talking about what we call the 90 days of preconception. This is a window of time we have to optimize egg and sperm quality. And so I'm going to jump right into the fun stuff here. And so to start out, I'm just going to give a few stats on fertility, just so we have an understanding of where our patients are coming from. So infertility is defined as the inability to conceive after 12 months in couples who are under age 35, and for couples that are over 35 years of age, 6 months. So about 15% or 1 in 6 couples in Canada will experience difficulty conceiving. And the top reasons why patients are seeking fertility treatment in Canada might be surprising to some of you. So we often assume that it's a predominantly female issue. However, the #1 reason in 2021 was unexplained infertility. So meaning we can't actually find a reason in the male or female partner for the lack of conception or pregnancy. The second most common reason was male factor infertility, and then that was followed by advanced reproductive age and diminished ovarian reserve. So I thought that was interesting. The number of fertility treatments that patients are seeking in general is also increasing, so it's becoming more of a demand. And so between, say, 2021 and 2022, there was about a 27% increase in the number of fertility cycles. And there's also a big increase in the number of social egg freezing. So this is becoming more popular amongst individuals who are trying to preserve their eggs for future use. So between 2021 and 2020, we know there was a global pandemic going on in there, and there were some closures and things like that. But the number of cycles increased by about 80% from pre-pandemic time until post-pandemic. So pretty big increase. So the preconception period, is a 90-day period immediately prior to conception. And this is a period of time where the eggs and the sperm are going through some changes. So from a spermatogenic cycle, it takes approximately 96 days for sperm to completely turn over. The ovarian cycle is about 90 days for those follicles to develop and mature. So during this time, those cells are going to be vulnerable to their current environment. So things like age, which we can't necessarily control, but other things that we may be able to control, like nutrient status, so deficiencies or excesses, exposures like pesticides or medications or chemicals, stressors, things like genetic variabilities or immune disorders, things like infections and endocrine disorders like maybe PCOS or diabetes, endometriosis would all be things that we know that it can affect the egg and the sperm quality. So this picture gives us a bit of an image of the piece of the 90-day period where we can actually, or the folliculogenesis cycle, that we can improve or optimize the quality of the eggs. So many females have already know by the time they're trying to conceive that they are born with the number of eggs in their ovaries. So we have some primordial follicles here that are there since birth, about 400,000 eggs at birth, and they're going to remain sort of suspended in time until sexual maturity or puberty. And at that time, they start responding to hormones. So specifically FSH and LH are going to cause those eggs to grow and mature. And so typically in a given monthly cycle, we're going to develop about or activate about 20 primordial follicles. Typically only one of those will ovulate and become a dominant follicle. The rest of them are going to provide a little bit of endocrine support to the ovary, but essentially one of them will be that dominant follicle. In the instance of, say, an IVF cycle or an oocyte preservation cycle, we're going to give, or the doctor is going to give medication to stimulate those ovaries, so higher doses, and we're going to get or try to get more of those eggs to grow. So in that period of time, there's a couple of things that we want to do. We want to make sure that those eggs or sperm, if we're talking about male factor, have the proper building blocks for cellular growth and maturation. So we think about specific nutrients in that period of time. We want to protect the nuclear DNA. They're going through some chromosomal separation, so phases of meiosis in that period of time. And we also want to support mitochondrial function, which supports our cellular energy processes. So in terms of our egg cells, they have a lot of these mitochondria. So mitochondria, if we go back to grade 9 science class, are the engines of our cell. They produce energy or ATP. And oocytes in particular contain many, many mitochondria. So more than any other cell. So about 500,000 by the time they're ready to ovulate. Sperm, on the other hand, contain typically very few, about 100. Also important for sperm and mostly for sperm motility from a mitochondrial perspective. In the lens of an egg, at the beginning of the 90-day period, it'll have very few of those mitochondria, and it's going to basically replicate and divide those mitochondria for that 90-day period of time. So we're trying to supply them with the tools and the energy in order to do that. Now, mitochondria are very vulnerable to things like oxidative stress or damage. So they're going to mutate especially fast, much faster than our nuclear DNA. And so that's one of the reasons we want to protect them in this preconception period. The other piece of this is that all of the mitochondria that are passed on to the embryo are maternal in origin. So if we look here at our little diagram, we have a nuclear DNA. We've got a copy from both sets of parents. Our mitochondria come from that maternal origin. So essentially the eggs are banking enough energy to grow the embryo in that period of time. So once fertilization occurs, we have the embryo sort of the cell is going to divide and make more and more and more cells, and it's going to share that energy from the mitochondria throughout those cells. If the egg did not bank enough energy in that 90-day period of time, then we don't get an embryo at the end of that embryogenesis, essentially. So they're pretty critical for egg and sperm quality. So why do we care so much about mitochondria? So we said that their primary goal is to make energy, and we have so many mitochondria in the egg. Basically, what we want to do is we want to support the energy pathways so that we can increase the cellular energy capacity and then therefore improve the quality of the egg and the sperm. So specific nutrients, like our fatty acids and our carbohydrates, break down to things like glucose and fatty acids. They're going to get shuttled into our mitochondria and they're going to start to make energy. We need things like carnitine. So carnitine is a supplement that we can use to support that phase of the mitochondria. Another example we might hear about is coenzyme Q10. So coenzyme Q10 is part of the electron transport chain to make that ATP. And so if we supplement with CoQ10, we can increase the amount of energy output from that cell. So basically, using supplements can enhance the number of mitochondria within the cells. It can protect the mitochondria from oxidative stress, and they can also enhance their function, so churn out more energy and make a more energetic embryo. So the primary goals of preconception care are going to be to improve the health of the individual so that we can therefore improve the health of the egg or the sperm prior to conception. In the lens of an egg freezing cycle, or if we're banking embryos, it's going to be from a fertility preservation. So we want to freeze the best cells possible so that we can ensure a better insurance policy. Preconception care improves reproductive and fertility outcomes. So healthier people make healthier cells and healthier humans at the end of the day. Preconception care ensures that we have the proper building blocks to make healthy egg, sperm, and embryo. And it also ensures that we remove things that are going to be detrimental to the health of our fertility or the cells. It's going to help us protect against any type of DNA damage and also optimize mitochondrial function. So it sounds like a good idea. So let's see how we can assess patients in terms of their preconception health. So I've broken this up into things that are typically done by like a naturopathic doctor like myself versus things that might be done by the fertility clinic or a reproductive endocrinologist. So in my clinical scenario, typically patients are going to be being seen by multiple practitioners. So they may have already had their, day 3 hormones and their ultrasound and sonohistogram done that we learned about last week. I'm going to be looking through a slightly different lens. So I'm going to be assessing for nutrient deficiencies, especially ones that we know that will impact fertility and ones that we know are sort of very common in our population in Canada here. So vitamin D, B12, iron. I look at beta carotene and vitamin A. So beta carotene can actually block estrogen receptors in certain instances, and it's in a lot of prenatal vitamins, for example. Things like cholesterol levels and inflammatory markers, glucose, insulin, hemoglobin A1C, and we often are assessing for insulin resistance using the HOMA-IR, which we find can pick up earlier cases, which can contribute to egg quality and implantation failure. And in terms of advanced cases, I might be looking at some more advanced testing, micronutrient testing. I think of things like omega-3 or CoQ10 or antioxidant status. Some people might be genetically predisposed to having low levels of these types of things. In terms of SNP testing or genetic testing, that's not something that I can do personally, but I can refer out for that. And that type of information is sometimes helpful to create preconception plans in really advanced cases. And I think about that in patients like recurrent pregnancy loss, or even poor responders, diminished ovarian reserve, things like that, or patients that have failed IVF cycles is another one for no good reason or an unknown explained reason. Assessing for body composition, so either by calculating BMI or assessing body composition with a BIA machine or body composition machine is also beneficial. So we know that there's a lot of impact on obesity and being underweight through the lens of fertility as well. So in terms of other types of assessments, so a dietary assessment is where I typically start. So food first is my motto. If we can get it from food, that's ideally the best. And obviously our diet is our building block for all of those cellular processes and components. So through the lens of fertility, the most evidence-based research diet is the Mediterranean diet. So most of the information we find is going to be roughly and loosely based on that. So that's going to include things like a low glycemic diet, adequate amounts of protein, making sure we include vegetable-based proteins in particular. It's going to include omega-3 fatty acids and plant-based fats. lots of antioxidant-rich fruits and vegetables. We want to avoid pesticide residues and things like that, and possible. And some dairy products are acceptable. We have different rules of like how much fat should be in dairy products, depending on if you're male or female. But in general, if you can tolerate dairy, there's no known harmful effect of them on fertility. We do recommend limiting or removing certain things that are detrimental to fertility. So study after study has sort of pointed out that trans fats, high glycemic diets, including high levels of carbohydrate or simple carbohydrates, high levels of animal protein intake, specifically red meats, and high levels of soy protein in men specifically, are all shown to affect pregnancy outcomes, lower hormonal output, that type of thing. In terms of diet, we also want to consider specific populations. And so, some patients might be vegan, they might have specific food sensitivities or allergies where they're avoiding specific types of food groups. Those types of things might make us more susceptible to certain nutrient deficiencies. So keeping an eye on that is something that we want to be mindful of as well. So in terms of body composition and BMI, we know that diet and physical activity play an essential role in weight management, hormone metabolism, and alterations in body composition and BMI affect both women and men who are under and overweight. So being underweight in females, for example, can stop ovulation and as well menstruation. Being overweight or obese can negatively impact ovulation as well. It also impacts egg quality from DNA damage, as well as it interrupts follicular maturation. So we don't get a mature follicle ovulating, and therefore it's not fertilizable. So women that are overweight also have 3 times more cycle disruptions, so oligomenorrhea or amenorrhea, for example, and certain conditions that are commonly associated with obesity, like PCOS or insulin resistance, are definitely known to impact fertility outcomes as well. Women who are obese often need more fertility medication as well during treatment cycles. So it does tend to dampen the response to those medications. So weight loss of even 5 to 10% of baseline or of their current weight, can help to improve hormonal balances, restore ovulation and fertility. In men, obesity is linked to things like DNA damage, decreased ejaculate volume, low sperm parameters straight across the board. Low BMI in men is a problem as well, especially low body fat or very low body fat, lowers hormone output as well as sperm count. So with being overweight, often we associate that with insulin resistance or just insulin in general. So insulin is a hormone that allows glucose into the cell. The glucose then heads straight to the mitochondria. It's going to help to make energy, that energy we're looking for of ATP. When insulin resistance occurs, the insulin in circulation is higher than it should be, and the body stops responding to it. So it gets a bit desensitized to that signal. And so if glucose is not efficiently moving inside the cell, we're not going to get it into the mitochondria, and then therefore we're not going to get energy production. So that's going to lead to things like lower numbers of eggs retrieved in IVF or egg freezing cycles. It also reduces fertilization rates and embryo quality as well. Insulin resistance is also linked to things like higher rates of aneuploidy or abnormal embryos, increased miscarriage rate, reduced pregnancy rate on IVF cycles. So the control group had a 23% pregnancy rate in this particular study versus 3.4% in the insulin resistant individuals. So it was very obvious that there was a problem. During pregnancy, if there is insulin resistant in the preconception period, that individual is much more likely to have things like gestational diabetes, increased miscarriage rates, preeclampsia, preterm labors, et cetera, et cetera. So placentas in general are insulin resistant. So if we have insulin resistance before, it just sort of snowballs into it. Pregnancy rates are decreased by about 5% every time we increase a point in BMI over 29. So really, we want to be keeping our BMI patients in between 20-25 in that normal range, certainly under that 29 points when at all possible. So sleep is our best antioxidant. When we're sleeping is when most of our cellular repair processes are happening. It's when our body produces melatonin, which is a very potent antioxidant as well as a hormone. And when we have poor sleep, we have increases in oxidative stress as a result of that. So that leads to things like menstrual dysfunction. So it affects the egg quality. So it takes longer to ovulate, or we don't ovulate at all. It affects menstrual pain and dysmenorrhea, decreases pregnancy rates, increases miscarriage rates. Whoops, sorry about that. Where was I? And also lowers birth weight in babies. So sleep is very important in both preconception and pregnancy for females. And then if we look at our male patients, we have many different sleep patterns that will affect testosterone output and sperm count. So the gist of this slide here is things like pulling an all-nighter, things like working night shifts, things like insomnia, where somebody's sleeping for 2 to 3 hour stints at a time, a combination of short sleep time and late bedtime. So if you're going to bed, say after 11:30, before 2 a.m., and you're only sleeping less than 7.5 hours, that was rated with significantly poorer sperm quality on sperm analysis. Screens before bed is also associated with poor sperm count. That's because of the blue light wavelengths that decrease and suppress melatonin production. Okay, so stress. Stress is always an interesting one because in some cases, we believe that stress impacts fertility, and then we know fertility impacts stress level. So it's like a bit of a chicken or the egg kind of situation sometimes. So we know mood and stress levels and specifically the neurotransmitters and hormones associated can influence the incidence of a live birth. So they can decrease the live birth rate. High anxiety levels decreases fertilization rates. Increased levels of stress hormones like cortisol and epinephrine also directly impact the ovaries and the testes. So we have sort of two modes of our nervous system. We've got our sympathetic fight and flight. So if we're stressed or, something is happening, all of our blood flow is going to our brain and our extremities, our heart, our lungs. So we're going to have to run or fight in that circumstance, in that fight or flight. So if we're in that stress mode all the time, the last thing on our brain's mind is reproduction, which is going to happen when we're in parasympathetic mode, or that, relax and reproduce mode, when the blood flow can sort of take a break from all that other high stress mode and go into those deeper areas of your body, like your digestive tract and your reproductive tract. So how we fix this is always a common topic around the clinic. So the more I think of stress management techniques like exercise, where the more we do them, the better we get. The more stress management techniques we have, the easier it is for our body to come back to a lower stress state once we've experienced a stress or are experiencing a stress. So we talk about a lot of different stress management techniques. It doesn't really matter which ones people choose, as long as it works for them and they do them. So things like appointments for fertility patients, blood work, cycles, cancellations, the financial stress of it, plus having, life and a job and all of those things at the same time. We certainly see significant amounts of stress. Things like exercise is obviously a good outlet. We definitely recommend counseling and therapy sessions for all the patients. Acupuncture is known to reduce cortisol levels. Guided meditation, we recommend a lot of those meditation apps, Breathe, Calm, Insight Timer. We use one called Circle and Bloom for fertility patients. journaling, breathing exercises, self-care like massages and baths and stuff like that. Whatever works for them, that's what we want to promote them doing, any type of self-care. So also screening for endocrine disrupting chemicals is something that I'm doing quite often these days. So, there's a list of things here, but if we think about it, the number and amount of toxins that we are exposed to every day is kind of shocking. So we don't really think about it most of the time. These products are sort of ingrained into our regular everyday routines, things like makeup and body lotions and plastic storage bags and plastic wraps that contact our food, those thermal sales receipts that we touch every time we purchase something. All of those things contain chemicals that interfere with our hormonal and reproductive function. They are all absorbed transdermally, and those are just some of the examples. We're exposed to things when we eat, so styrofoam takeout containers or foods with pesticide residues, things like that. We just came through a pandemic where we were using hand sanitizer everywhere we went, grocery stores. Hand sanitizer increases the absorption of things by like a crazy amount. It's like 1,000%, especially BPA. And it's in those sales receipts. So we're, rubbing our hands down at the grocery store and grabbing that sales receipt. So these are the type of things that we can reduce if we're conscious and paying attention. I refer patients, instead of sort of, going through everything they own, I refer them to a couple of apps. Usually the Environmental Working Group is a great resource. They have an app called Think Dirty or Skin Deep. It's one of the two. There's one's the website, one's the app. There's an app called Yuka, Yuka. Really amazing information. And if, you can scan anything that you own, your makeup or your deodorant or whatever, and it gives you a grade, red light, yellow light, red light, or green light, yellow light, red light on how good or bad it is for you, and can suggest better alternatives. And one of the things I like about that app is it actually has practical advice. So if it actually affects your reproduction, it'll say why and how and what the ingredient is that is problematic. Because sometimes if I say to somebody like, don't use those makeup wipes, they're not that great, like they don't believe me or they don't know the significance, so they don't necessarily listen. But if they see, it's got a reproductive toxin in it, then they're going to be more likely not to use that right now. So BPA is one of the main things that we're talking about. BPA is an endocrine disruptor that blocks estrogen, insulin, testosterone. We know that there's impacts on both female and male fertility. So it's toxic to DNA. So it will disrupt both egg and sperm cells, lowers hormone output. So endocrine disruptors, basically, it's like a lock and a key. So it fits into our hormone receptors and blocks the site. So it can either block an action or it can potentiate an action depending on what it's doing. This BPA was discovered as a fertility toxin in animals by accident. So they had been using rats for fertility experiments, and all of a sudden the rats had their normal DNA fragmentation or defect damage rate was about 1% to 2%, and it increased to about 40% all of a sudden. So what they discovered was that they had washed the water bottles that was in the rat cages with a strong detergent and hot water. So now BPA was leaching into the water and created the toxic effects. So once they swapped that out, the DNA damage went away and it went back to the previous rates of 1% to 2%. So it definitely has a significant effect on our DNA strands. Alcohol. So, there are so many recommendations about alcohol depending on what lens we're looking through. I know recently many of us heard from Health Canada that alcohol, I think it was 2 drinks per week was the new recommendation for general health type things. In terms of alcohol, what I will say is, in general, abstinence is best when we are trying to actively conceive. I usually tell my patients if they're doing a treatment cycle with medication and they're paying all this money, then they definitely should not have alcohol, because there's definitely known decreased fertility outcomes when you're consuming alcohol in the month before and the month during your fertility treatment. Now, if you look at alcohol intake as a whole over an entire year, It doesn't seem to affect pregnancy rates and live birth outcomes, but it does seem to have an effect in the sort of current use undergoing fertility treatment. Better to avoid is the mantra on the alcohol intake. Cigarette smoking, we know we want to avoid that too. There's over 4,000 chemicals in cigarettes that are cytotoxic, so they're going to damage DNA in both eggs and sperm. So it definitely affects ovarian reserve in women's. We see lower numbers of eggs, fewer eggs, because they've been killed off typically by the carbon monoxide. Cigarette smoke also affects the uterine environment. There's a significant increase in ectopic pregnancies in smokers compared to non-smokers. Destroys the cilia in the fallopian tube, so the embryo can't travel down as well. Even donor eggs are less likely to implant in smokers. Cigarette smoke also negatively affects the placenta. It affects blood vessel development. So anything that affects blood development is not good for placentas. In men, cigarette smoke basically affects every single sperm parameter that we can measure. It also introduces lead into the seminal fluid, so that's not really good either. Causes cell mutation, cellular death, very, very low sperm counts often. Marijuana, so both the ovaries and the testes contain cannabinoid receptors, so it definitely disrupts ovulation, follicular development, and spermatogenesis. So we see poorer egg quality and lower pregnancy rates in females. We see lower sperm motility and lower functioning of the fertilization capacity of sperm. So it's called the acrosome. It's like a little head on top of the sperm, and it's responsible for fertilization. So that becomes damaged with exposure to cannabis use. Male partners using cannabis once per week showed a much greater risk of miscarriage with their during pregnancy. So that was an interesting study as well. So we don't recommend THC use or CBD use in preconception. Occasionally I go through the conversation of risk reduction, meaning like if you're smoking it, maybe gummies or topical use is better. There's absolutely no evidence for THC and CBD as being better by any means. And what I mean by that is the combustion of the smoke is potentially gone. So we might reduce the oxidative stress from that, but we're still being exposed to the CBD or the THC. So still not recommended. Caffeine, so caffeine, like alcohol, is toxic in high enough doses, and that just depends on your ability to metabolize caffeine in general. So we do see consistent results with high doses of caffeine and negative impacts on fertility and pregnancy outcomes. So 500 milligrams of caffeine per day, which is about equivalent to 5 cups per day, definitely increased time to pregnancy. In most cases, 9 months or longer to conceive. High doses of caffeine is increased to miscarriage. So there was a meta-analysis here that I mentioned. 300 milligrams a day or more was associated with fetal loss. And then in another study, 100 milligrams per day was associated with an increased risk of miscarriage as well. So the take-home message, we recommend, if you need it, 1 small cup of coffee per day, a 6-ounce cup of home brew, or a small espresso, single ounce, which is going to keep you under that recommendation of 300 milligrams per day. If you are one of those people that is sensitive to caffeine in the first place, so if it makes you shaky or hypoglycemic or ragey or gives you anxiety, better to avoid it. You probably have a genetic predisposition to poor caffeine metabolism, and it can cause problems for those types of individuals. So supplements, in terms of supplements, what I would say is we've all heard of folic acid for pregnancy. Often I have had patients come in and say, well, I'm just freezing my eggs and I'm not going to be pregnant, so I don't need folic acid. I disagree with that wholeheartedly. Health Canada says we should take a prenatal vitamin or folic acid for 3 to 4 months prior to conception. And so it does prevent spina bifida and neural tube defect, yes, but also it helps with DNA replication and cellular division and methylation and things like that. So definitely folic acid is for beyond pregnancy. all vitamins and nutrients are used somewhere along the line for embryogenesis, folliculogenesis, spermatogenesis. And there are some common nutrient deficiencies, even here in Ontario. Iron, vitamin D is the top one I see in my practice by far, vitamin B12 and calcium. So these are things that we can sometimes get from our prenatal vitamins. And so prenatal vitamins, I just wanted to comment on, because if we go to the health food store, as we know, there's a million of them on the shelf. They're not all created equal. So we take a lot of things into consideration. Cost might be one. There's one that's covered by insurance. Over-the-counter brands versus professional brands would have different forms of vitamins in them. There's variations in formulas, and this is what I pay attention to. So not all my patients are different or the same. Some are vegetarian, some are not. Some have allergies, some do not. So their needs will be different, and we will choose based on those needs. And there's also things like therapeutic doses, not just for prenatals, but for any type of supplement. So I'll often get the question, like, can I get, X nutrient from my diet instead of taking all these pills? If we're aiming for therapeutic doses, like we are for something like egg quality or prenatal care, typically no, we do need supplements some of the time for that. So for example, my favorite example is if you want to get your 400 milligrams of coenzyme Q10, which is a moderate dose, you're going to eat about 8 pounds of cow or chicken hearts per day to get that amount. So most of my patients are not going to be willing to do that, and they'd way rather swallow the capsule. Things like absorbability. So iron's a popular one that, ferrous glucarate or ferrous succinate might not be as well absorbed in somebody. It might cause nausea or constipation, and an iron citrate or glycinate might not. Bioavailable forms. So that might be methylcobalamin versus hydroxycobalamin. In terms of vitamin B12 forms inside of a prenatal. So some people might have issues with one form or the other. So methylcobalamin sometimes will cause anxiety in sensitive people, for example. And then they all have different fillers, artificial colorings, flavorings, additives, or not. And I will choose things based on those, especially if patients have allergies to certain things. So folate levels, I mentioned already a little bit. So we know it's for beyond just pregnancy. It's also for preconception, strong role in DNA, RNA replication, protein synthesis, and DNA protection. So it's involved in the methylation cycle, which basically protects the genome from damage during that preconception phase. So folic acid deficiency is also linked to some serious complications. So it causes an increase in homocysteine levels, which causes inflammation and oxidative stress. So that increases the risk of things like neural tube defects in spina bifida, but also pregnancy loss and those types of pregnancy complications. So the recommended daily allowance of folate, 0.4 micrograms pre-pregnancy, 0.6. We usually don't recommend above 1 milligram unless you've got significant risk factors. So vitamin D, I mentioned, is likely the #1 deficiency I see in my practice, often referred to as our sunshine vitamin. It actually works a lot like a hormone. Receptors in every tissue in the body, including the ovaries, the endometrium, the placenta, the testes, on the sperm itself. So it assists with the development of ovarian follicles. It improves the thickening of the endometrial lining. We see a seasonal correlation in pregnancy rates, especially in animals who hibernate, but also any type of mammal. But when vitamin D levels are the highest, so when the sun is out, spring and summer, there's a higher pregnancy rate than when the months that vitamin D levels are naturally lower. And sufficient levels in pregnancy definitely reduce risk of pregnancy complications, impaired fetal bone development and whatnot. And male fertility, vitamin D plays a huge role in hormone production, semen quality. It has a big effect on the acrosome, so that fertilization component on the head of the sperm, which is loaded with vitamin D receptors. So we have to make sure our male patients have adequate vitamin D, so they display an adequate number of vitamin D receptors for fertilization. And it also has an impact on PCOS. So having adequate levels of vitamin D can modulate AMH levels, which tend to be abnormally high in PCOS, improves insulin resistance, and can normalize ovulation in women that are deficient. So from an IVF perspective, we know that women with adequate vitamin D levels are more likely to have pregnancy and a live birth, and actually 4 times the pregnancy rate of those with vitamin D deficiency. Based on a 2010 study, between 70 and 90% of Canadians are deficient. And typically that, 600 IU recommendation put out by Health Canada is not enough to keep us into that range. Most of my patients are getting 2,000 to 4,000 on a regular basis. I measure everybody. I try to keep them in the range of about 100 to 150. I use a vitamin D calculator. It's called Grassroots. You can find it online. And it can, you put in their current level and their current dose and their body weight, it helps you calculate how much they should take based on their current level. So it's pretty cool. So inositol is another supplement that we might use in the fertility setting. So it is a B vitamin. We hear about it a lot for PCOS. So in PCOS, it can help improve ovulation rate. It can normalize androgen and lipid levels, which are often augmented in PCOS patients. Mostly using about 4 grams of myo-inositol. Specifically in PCOS patients, it increased the number of oocytes retrieved. Sometimes in PCOS, we'll actually see a lot of the eggs don't respond to fertility medication. So that's kind of a cool thing that inositol can do. In women that do not have PCOS and have insulin resistance, it's also effective. This time it doesn't increase the number of eggs retrieved, but it improves egg quality. So inositol concentrates in follicular fluid as the egg approaches ovulation and protects it and improves the quality. So again, 4 grams per day is the recommended dose. It's also used in male factor fertility, improves fertility, improves motility. And again, that acrosome or fertilization component. And we use it a lot for anything to do with FSH and LH secretion. So it's a very good balancer of those, both in male and females. So even in women who are poor responders in IVF, who are not insulin resistant, inositol can sometimes improve the cycle outcome. It's also safe during pregnancy, which is one of the other reasons I really like it, because if I have them on it for preconception and they conceive and they've been insulin resistant, we can carry it right on through. So CoQ10, most of my patients will already come into me taking this one because they've read all about it online. It is known for its role in energy production, and it's a mitochondrial nutrient specifically. So it helps to pump out more ATP. It's also an antioxidant and an anti-inflammatory. It's found in all of our cell membranes. And we actually start to decrease CoQ10 levels naturally in our body by age 30, which isn't that interesting how that lines up to our decline in fertility. So CoQ10 is indicated for advanced maternal age. We use it in poor responders, especially those that don't respond to Clomid if they have PCOS, can improve the response. Any type of mitochondrial support for pregnancy loss or egg quality, it's beneficial. And from the study perspective, now, if we look at animal-based studies, CoQ10 looks amazing. So it increases the number of oocytes in the animals, and it also increased live births. And when they give CoQ10 to older mice, the mitochondrial function and the spinal alignment that are disrupted in older mice was reversed and corrected. So basically improved the egg quality and the ovarian reserve, and it restored mitochondrial gene expression, which is pretty cool. So in human studies, not as obvious in terms of its effect. Women and men are not mice, unfortunately, and our life cycles and fertility cycles are very different. But the use of CoQ10 in the preconception period is associated with an increased response to fertility medication in both IVF and egg quality or egg freezing cycles. It also improves embryo quality, especially in women with diminished ovarian reserve or few eggs. Typically, we're using about 600 milligrams. People ask about ubiquinone versus ubiquinol all the time. It does not matter. In terms of male fertility, we use CoQ10 for concentration, motility, and to protect the DNA. So DNA fragmentation also can improve morphology. Anywhere from 200 to 400 is usually what's recommended. 300 is a nice one in the middle there. you'll see that's kind of the dosage that's used in a lot of the studies and what's in a lot of the male factor products. So it can increase sperm count, it can increase motility by quite a bit, and morphology. So a 3% increase in morphology is actually pretty good. It can sometimes be hard to fix morphology in sperm. So last nutrient I'm going to discuss this evening is melatonin, and we talked about it in terms of sleep deprivation already. So it is our hormone. It is also an antioxidant. Melatonin receptors are virtually found everywhere, including ovarian follicles, embryos, placentas, testes, sperm, and it's produced locally in the ovaries. So as the ovary approaches ovulation, the level of melatonin in the follicle increases, and that's a way that it protects itself from oxidative stress associated with ovulation. So higher levels of melatonin are associated with better egg quality, better embryo quality, better fertility outcomes in general. And so typically screening for sleep disturbances and things like that. But even in patients that sleep fine, melatonin is still shown to be effective as an antioxidant for fertility. And I think, is that my last slide? Yeah, so in terms of a recap here, spending some time to prepare a patient for that 90-day period before they do an egg freezing cycle, before they do an IVF cycle, improves the health of the patient, improves the health of the cells, improves the health of the pregnancy. And so our motto here is your health, their future.
Thank you for that. We've had a few questions come in as you've been talking, and if anyone has any others that they want to ask, you can, I believe you can ask them out loud, but I'm not exactly sure on that, but you can enter them in the Q&A. The first one, someone asked, with respect to a diet, do you have specific diet info that you, I think it's looking kind of like, do you have it that you would direct patients or that they can direct their patients to? Do you have a blog or on your website where you have kind of a general overview of the best diet recommendations for fertility patients?
I'm not sure if our dietary handouts are specifically on our website, but if you guys want a copy of like our general fertility diet that we distribute, I'm happy to send that to you, Tavia, and you can, is that like a thing you can do and send it out?
Yeah.
Or we can attach it to the presentation somehow, maybe. So, I mean, we do have dietary information that we give out to our patients. Now, I spend like my visits with my patients, if it's an individual, my first visit is 60 minutes, and if it's a couple, I spend 90 minutes with them. So I actually talk to them. I look at what they're eating, and I actually like, give them suggestions based on what they're eating and how they can improve that. So, some of my patients are coming in and, they're a holistic nutritionist and they already eat really well. Some of them are eating, not enough protein or not enough fat, and they're like low calorie. The other ones, might be coming in and eating a lot of simple carbohydrates and fast food and things like that. So everybody's coming from a different place. So I try to keep it, general so that not everybody feels like it's a massive life decision. And I like to focus on like the small things we can do to improve versus like all the negative things that they're doing, if that makes sense.
Yes, and I think the next question kind of piggybacks on what you just said, but are there specific recommendations for vegans trying to conceive that you would?
So yeah, I mean, vegans are tough sometimes. I've convinced many a vegan to start eating a little bit of animal protein again. I'm not going to lie, because sometimes I actually see a result in the egg quality on their IVF cycle. And so if we have chronic protein deficiency, so if somebody's, bordering 30 or 40 grams of protein for an extended period of time, I'll actually see that in the egg quality sometimes. So number one, I instruct the vegans to make sure they're hitting the minimum protein requirements. That's number one. And then I talk about a few specific nutrients that are very low typically in plant-based diets. So choline is one that nobody ever talks about with patients. So it's also involved in that neural tube defect spina bifida. So choline, spelled CHOLINE, if anybody's not familiar with that. It's one of those nutrients that's not mandatory to be in a prenatal vitamin, but it's mandatory to close the neural tube and for spina bifida prevention, DNA protection, those types of things. They did a study a few years ago, and 96% of the females that they looked at did not get enough choline in their daily diet, and most prenatal vitamins have 0. So it's mostly an animal protein. There is some in things like soy lecithin and sunflower seeds and things like that, but I supplement my vegan patients often with things like that. Omega-3 is another one I'm often considering. So DHA in particular, there's no source that's not animal-based unless it comes from algae. So unless patients are eating a ton of algae, which, you know, a lot of them are not, they're not going to get those essential fatty acids. So that's another one. You know, B12 and iron are easy. That's going to be in most prenatal vitamins. So we're not, you know, as long as we screen for those ones, we're okay. They're likely going to be low in vitamin D because, again, any diet, like a lot of the dietary sources are going to be animal-based. CoQ10, like a lot of animal-based, because, you know, muscle has higher numbers of mitochondria than plants. So those are the types of things that I'm looking at in vegans.
Okay, I think that wraps up the questions. What I wanted to say is I know Dr. Fitzgerald brought up a few different apps and sites and that she uses in her practice. So we will link those when we do share this video, and when we do share it, we usually share it to a YouTube site. So it will be linked in the notes there for anyone who is watching this presentation on YouTube, just to give you a little help in your practice with some of those tools that you can bring into play when you're seeing your patients. So that is all we have for you tonight. Thanks for joining us. Hopefully you can join us for our third talk, which I believe is in April. We have March off, and then we have a talk in April. And thank you very much for the talk tonight.